Hi, I'm Dr. Ashley Fuller.
And I'm Dr. Meredith McClure.
And this is Labia Logic,
the podcast that's all vulva, no filter.
We're here to talk about all the stuff your doctor rushed through, the questions you've been too embarrassed to ask, and the sex ed that barely mentioned the vulva.
Because too many people are suffering in silence with painful sex, menopause misery, and vulvar issues no one talks about.
No shame, no stigma, just real talk, real answers, and the education you should have gotten in the first place. Hello, welcome back to Labia Logic. We're happy to have you back. We are in the third part of our series about painful sex, Missionary Impossible. And today we're talking about Too Tight to Tango. I'm here with Meredith, and Meredith's going to introduce our guest for us.
Thanks, Ashley. So in our 3-part series, we've done hormones and how they can make a difference in our vulva and vagina when it comes to pain, and then nerves and how an overgrowth of nerves can actually lead to pain in the vulva. And now we're going one level deeper, which is going to be muscles and also nerves. And these are things that Ashley and I, we don't do, we can't do. We aren't trained in it, but we recognize when it's a problem, and we have to phone friends. And one of the integral friends that we have on our team is a pelvic floor physical therapist. And Sara Sauder, who's here with us today, is one of my pelvic floor physical therapists, and I can't live without her. In fact, I tell her I would probably cause her bodily harm if she were to ever leave, and she knows that because I can't do my job without her. And we met 3 years ago, take care of a lot of patients together, and I'm happy to introduce Sara Sauder. And why don't you kind of introduce yourself? Tell us who you are, what you do.
Thank you for having me. I am a pelvic floor physical therapist. A lot of people don't know that physical therapists treat the pelvic floor. Some physicians don't know that. Some therapists don't know that. But there is a whole specialty where we treat pelvic floor issues for men and women. And I got into this in 2009, and I've been treating men and women since then. I was in the Austin area, and now I live in Dallas, and that's how I met Meredith McClure. And I called her up one day because we had a mutual patient, and I liked what she was doing with the patient. And I thought, oh my gosh, I need to get this person's cell phone. I need to get them on the phone right now. I need to say hello. I need to say, I like what you're doing. Keep doing it. And I'm going to send you all my patients now. So that's how we met.
Yep, that's how we met. I don't know about you, Ashley, but I did not know pelvic floor physical therapy existed until I was a resident.
Yeah, I mean, I don't think I knew what it was. It's like, just kind of going through my normal life before medicine for sure. But yeah, I think we talked about it in residency a little bit, but even that, I don't think we did a ton about it in residency. And I think a lot of people don't know what, like when I tell patients you need to go to a pelvic floor physical therapist, they look at me with these blank eyes like, I don't know what that is.
Yeah.
I have my spiel of what I tell patients, but I would love to hear from you. Like, what is your role? Like, what do you do?
When I talk to patients, I tell them I do poop, pee, and sex, and then I'll add some stuff and any pain. When I talk to physicians who are like, how do I know when to refer to you, or what's a good referral? I say, okay, there's a couple of things. Number one, the patient that you see on your schedule that keeps showing up on your schedule and you don't know what to do with them, send them to pelvic floor therapy. Number two, if you can't treat it with a medication or a procedure, send them to pelvic floor therapy. It's usually the patients, like in the urology world, the patients are typically going to be guys with testicular pain. In the gynecological world, it's going to be painful sex, frequent infections. In the urology world for women, a lot of times it is frequent UTIs or symptoms of a UTI, and they're typically placed on a series of antibiotics over and over and over again. So if what you're doing isn't cutting it, consider that a pelvic floor therapist should be in the mix.
We hear from patients when we bring up pelvic floor PT, they all immediately say, oh, I'm going to need to Kegel. Can you comment on the Kegels?
The Kegel has its place, and its place is not everywhere. There is a very particular type of patient, and everything has to be right for the Kegel to be helpful. and not counterproductive. So the thing is that most people who need pelvic floor therapy, their muscles that make up the pelvic floor, which are in the vagina for a female and in the rectum for a female, these muscles are usually too tight because there are so many things in this world that are stressful, and we hold a lot of stress in our genital area. Also, when we're in pain, we tighten up our pelvic floor muscles. It's kind of like our way of protecting our reproductive parts. It's a very primitive, involuntary response most of the time. If we've ever had pain with sex, for example, we anticipate pain with sex, so we are going to tighten up to protect ourselves and kind of pull away. So if you're having any sort of symptoms of tight muscles, you should not be doing Kegels. So symptoms of tight muscles are basically everything. It can be stress incontinence, though that can be a sign that muscles do need to Kegel. Most of the time, I don't have patients that are only leaking with coughing, sneezing, laughing. They're also having intense urinary urge, or they're also having constipation, or they're also having back and hip pain, or they're also having pain with sex, or they're also feeling some burning when they urinate or don't empty all the way. These people should not be Kegeling. There are people I see for all of the symptoms above or any mixture of them where I will work on relaxing their muscles and then they still have leakage. Only then is it the right time to do Kegels. And I give them baby Kegels. It's more about the relaxing than the tightening. And I don't have them do an insane amount or an insane hold time. And I let them really appreciate your rest time is as important as the hold time. So do not power through it.
Can you say how you tell people to Kegel?
I actually will do a couple of different things. I like to teach people to Kegel with my finger in the vagina. A caveat to that is I actually am not a vagina-centric pelvic floor therapist. I think that there are some out there who are, where everything is in the vagina, every single treatment, and you just deal with the pain. If you have pain, I actually do so much externally. But if I have someone who does need to do Kegels, then we're out of the pain element. My finger's in the vagina, and I will give a variety of cues. First, I'll say, how do you think you do a Kegel? Let's see what they think it is. If it's not correct, I'll give them cues like, okay, the basic cue is imagine you're peeing and you need to stop. Okay, can you do that? All right, let's say they can do it. But is that really recruiting all the muscles, or do they have more to give me? So then I'll say, okay, now imagine trying to pull my finger that's in your vagina up towards your head using your muscles only. Let's see how that goes. I'll say, okay, imagine trying to bring your clitoris to your head. And if they still can't get it, I'll use some rectal cues, like imagine you're in public and you need to hold that fart back. And sometimes that's the cue that works for people better than others, but I always have my finger in there to feel that they are doing it correctly. Sometimes when I give Kegels, I do let them use what I call cheater muscles. I will have them use their abs because they're wired with the pelvic floor. Sometimes I'll have them use their butt cheeks. Sometimes I'll have them use their inner thighs, and sometimes I'll have them use their outer thighs too. And the opposite of that is people who are doing a lot of work with their abs, a lot of work with their butt to strengthen their butt, their inner thighs, their outer thighs. These people probably have vaginal and rectal muscles that are way too tight because those are essentially Kegels all the time, because I know these people are not doing a relaxing diaphragmatic breath after every rep. So it goes both ways, but that's how I teach how to do a Kegel, a couple different ways.
I might have been Kegeling that whole time.
You probably were.
It's so funny because when I see a patient and I think her pelvic floor is really tight and it's part of this equation of painful sex, I'll start talking about pelvic floor physical therapy. And a lot of times they'll tell me, I do my Kegels. And I had to kind of have this explanation, like kind of what you're saying. Like you have to be able to have this brain and body relationship with your pelvic floor, and you have to know when to tighten it and how to relax it. And I think that's like, I mean, I was just saying to Meredith, I was like, I don't really have a great relationship with my pelvic floor. I hold all my stress here. Well, sometimes I walk around and my shoulders are up by my ears and I don't know why I have a headache and someone has to tell me like relax. That some people hold all their stress in their pelvic floor. And like I think that's what you guys are so great at, is like helping people make that connection and learn how to relax those muscles.
Every day we say it's all connected. It's all connected.
It's super connected. And the other thing that I find so fascinating that it's taken me years of experimenting and paying attention to learn is that I say that I have what are called stupid fingers. I can feel if my finger's there. If you're doing a Kegel correctly, I can feel a contraction. Who can't? But my fingers are stupid. I do not trust if I personally, subjectively think your muscles feel tight. I go, but what I know physiologically, a tight muscle will hurt. And so if I put my finger in a vagina or a rectum and I'm not even thinking, is this tight or not? I'm saying, hey, is this pressure or does this feel like pain? That is how I make a decision on whether things are tight or not. Because again, tight muscles hurt. Muscles that can relax normally will not hurt. And so that's how I judge what is tight and what isn't tight.
Sometimes pressing on those muscles will make you even feel like you have to pee or poop.
Yep. So a lot of symptoms can come from there. The vagina is so fascinating. It tells us what to do. It tells us what's going on. I know we're not talking about vulvas at the moment, but I love vulvar exams. So when I do someone's history and I'm like, hey, tell me everything. Now I have invasive questions about your pooping, your peeing, and sex. And you're going to be like, wow, this girl's really going into details. I met her 5 minutes ago and she's asking about my orgasms. And I somehow am freely telling her. When I get that subjective, I am creating a picture in my head of what I'm going to see on a vulvovaginal exam. And so that is, vulva, what you can see in the mirror. I'm thinking, okay, do I think the hood of her clitoris is going to be stuck? Do I think the clitoris is going to be small? Do I think I'm going to find some signs of a skin condition like lichen sclerosis? Do I think her labia minora are going to be growing into her labia majora? Do I think her urethra is going to be sticking forward, telescoping, blinking at me? What am I going to see? And I do a Q-tip test around the opening of the vagina, and where people hurt, if they hurt, and the intensity of their pain tells me so much. So I love when I get symptom provocation through just testing, like pressing a muscle, ooh, I need to pee, or touching with a Q-tip, ooh, I need to pee. I love it.
Yeah. And you're so good at knowing, especially for my patients, their period history. And you tell me, you will talk to me about patients and be like, and she has her period. It's every month. She takes birth control pills, or she's menopausal. She's taking hormone blockers. Like you tell me all those things, which is so great because I think that's so important. You recognize that. And it's one of the things I love about pelvic floor PTs is that you don't just do joints and muscles and things like that orthopedic PTs do. You do visceral things with guts and bladders and bowels and sexual function, and you understand all that, and recognizing what long-term skin disorders that can create pain for people like lichen sclerosis patients that have had it for years without a diagnosis, and how that can cause tight muscles and pain and lack of hormones and kind of all the things we've been talking about so far in this series. And we can do everything we can for the skin and the hormones, but you really are the manual labor that helps us kind of push it past the goal line. Often I'll email her and say, all right, I've got her teed up. Now you just kick it through the goalposts and we'll get it better, and it's fun. It's a good collaboration.
Tell me more things you like about me.
She told me I would like you, and I already really do. So you sound amazing. I love it.
You brought up something there. Yes, this is obviously very collaborative, and just like, earlier today, I sent Dr. McClure Meredith a patient. I was like, okay, I do call it the manual labor. It's literally hand labor, but I do the manual labor, but I cannot prescribe, nor do I have the expertise in knowing what to prescribe and how to prescribe it. So I need that help. I have to have it on board. But I think the importance is knowing when you need to pull other people in and who those people are. But you also mentioned like visceral fascia stuff. The other fascinating thing about this being about vaginal pelvic floor muscles being too tight or rectal pelvic floor muscles being too tight, and I say I'm not vagina centric. How can I treat people for muscles that are too tight without always going inside the house, metaphorically being the vagina? I like to say the call is coming from inside the house, or the call is not coming from inside the house. So we have fascia, and that is the only thing in our body that's connected from head to toe. So if I were to imagine wearing a full body bodysuit and I pull that bodysuit of my left arm, I'm going to feel my right shoulder being tugged. That is how fascia works. And we have a massive fascial connection between our pelvic floor muscles, our vaginal and rectal area, our bowel, bladder, and sexual function, and our fascia. And so the biggest connection is at our abdomen. We have a huge connection with our inner thighs, our quads, our hamstrings, our butt, perianally, and low back. I actually most of the time work on people's fascia externally first. There's a ton of nerves running through there. It very much affects the nervous system. And what it ends up doing is it relaxes the pelvic floor muscles and the nervous system. I have found that there are truly people where I'll just do 1 or 2 sessions of fascial work on their abdomen and now they're not having painful sex anymore. I haven't even gone there yet. And that's not everyone, but it is a very common finding. So I think that's something unique to pelvic floor therapists that they can offer. Don't always offer, but can certainly offer. And you'll find magically, oh my gosh, burning with peeing is gone now. Oh my gosh, how am I having a full, complete, and pain-free bowel movement every day for the past week? This is unbelievable. It's because the nervous system gets affected. The other thing about muscles being too tight and staying tight is it basically turns into a contracture where no matter how much you volitionally stretch, literally stretch your hips or do a happy baby stretch or do a child's pose, you need that fascial improvement. And then eventually some people do need that manual input of a finger pressing down on a vaginal muscle, very tolerable amount of pressure to lengthen those muscle fibers. So there's so many ways to go about this in ways where people can wrap their head around it and say, listen, everything going in my vagina is very, very painful. I'm nervous you're going to hurt me. And I'll say, oh no, I'm not doing a pap smear. I'm not trying to feel your ovaries. I'm trying to recuperate what's going on here. So this should all be very manageable.
Fascia, it's a connective tissue. It's like you'd always describe it as like when you have a chicken breast and you're pulling that little filmy,
It doesn't
tight.
have to be a breast. It can be a leg.
Can be anything that has muscle.
Uh-huh.
And you can peel that off. That's fascia. And we have that as well. And it lays on top of muscle. And any insult someone has to their muscle fascia, it could be an incision from a surgery. You could have had an infection, an injury, whatever it may be. It could be a breast surgery. And then that fascia tightens up and binds down onto that muscle, which decreases blood flow and it's inflamed. And then that fascia just continues and it just travels and it is all connected. And all of a sudden, someone's having genital pain, and we're like, well, it might be coming from up there. And I think that's something that I learned by hanging out with you guys. And can you say like how you release that fascia?
You love for me to tell people how I do it.
Because I need to know, like, what does it look like?
It looks like this. It looks like I'm typing on a typewriter, like I'm a GIF, and I'm just typing that on a typewriter. But I use coconut oil to reduce friction, but I need some friction. I'll rub it on there, and I'll tell people this might feel like a rug burn. As I rub the coconut oil on, they're like, "This isn't so bad." I'm like, "We haven't started." But what I'll
Just
do
wait.
is just wait. You are type A. So then what I'll do is I'll lift the skin and the fat up, and I'll basically plow my fingers along. So it's a lifting, it's a distraction. What it isn't is a compression down. So it's really different from a massage. Massages typically are targeting muscles and they're usually compression downward. What it isn't is it's not a fascia blasting movement. Fascia blasting is also compression. It's not a foam rolling movement. That is also compression. This is a lifting. And the only thing similar to it is like using cupping, like you see the swimmers and they have the cupping marks on their backs, the circles. Cupping is the closest thing to it because it lifts and distracts. So for some people, it can be pretty intense. And I will say that you don't have to have a single scar on your body to need fascial work, but the people that I do see who I think literally 100% of these people need to do pelvic floor therapy for fascial work. If you had a tummy tuck, you need to do it to prevent issues down the road because eventually 3-4 years later, I see people with painful sex, frequent UTIs, constipation. If you have had like that excess skin removal and you have like the scarring on your arms, up in your inner thighs, if you have had a cesarean section, I think all women after 12 weeks after the cesarean should do one session just to work on that and to learn how to address your cesarean scar, but not just the scar, but the surrounding fascia. It's the same timeline for tummy tucks, breast implants, breast reconstruction, flaps, all of this 12 weeks later. I really think it helps you breathe, helps you move your arms, it helps with neck issues. I think everyone in that category needs it. And then all my collegiate athletes, my professional athletes, they don't necessarily have scars, but the way they overwork their abs, their butt, their hamstrings, the way they are just complete specimens, they are not doing anything to relax their pelvic floor afterwards. And that fascia is binding down like tight sausage casings. And so those types of lifestyles really need fascial work.
I'm giggling because Ashley and I both were college athletes, and I don't think anyone ever called us a specimen.
Um, you
We were not working our abs that much.
know,
I was. Come
so
on.
there's never a situation where someone was giving you a massage, you're like, relax your butt cheeks. And you're like, they are relaxed. They're just perfectly plump.
It wasn't
So
cool to
I
work
think this
out
fascia
then.
stuff is super interesting. So when someone comes to you, like, we refer a patient for painful sex and we think her pelvic floor is involved because spoiler alert, it almost always is, right? You already told us like how you take this intimate history and are thinking about what things look like, but how is your process for when you're examining them to figure out where in the fascia is there a problem? Is it the fascia? Is it the muscles? And like what kind of treatment that you would provide for them?
If they're coming for painful sex, I need to know at what point during sex are you hurting? And I will always pull out my finger and say, I'm about to be very crass because I'm trying to be polite. I don't think this is crass. This is just like a really basic stick figure
Yeah.
metaphor. I'm holding my hand in a kind of a very open fist, allowing there to be a hole where a finger or penis could go through. So at the opening would be like the vaginal opening. And then I say, okay, if a penis, a tampon, what finger, a toy goes in, does it hurt at the opening? Yes or no? Okay. Now, as it goes in, does it hurt with the back and forth in the middle in the vaginal canal? Yes or no? Okay. Does it hurt at the end? Does it feel like there's a wall being hit? These are three different scenarios, and people could have all three situations going on. But if it hurts at the opening, I think, okay, I've definitely got to check the vestibule, which is my favorite female body part. So I'll do a Q-tip test for sure. And I'm going to ask, are you doing vaginal estrogen cream? Are you on an estradiol testosterone cream? I will also want to know about other products that they may have used that can affect estrogen, testosterone in the body, like oral birth control, spironolactone, IVF medications, Depo-Provera, Nexplanon implants. Then, if they have pain in the middle with the thrusting, are you on vaginal estrogen? What does it feel like? Do you bleed? The vaginal canal we know is like a slinky. It should be able to expand and shorten, and it expands when the body is aroused, wants to have sex, and goes through physiological changes. So we know that if the body doesn't want to have sex, it's not really well lubricated, it's not moving nicely. And then your cervix, if you have one, or your cuff of your vagina, where the cervix would have been removed if you don't have one, is going to be closer to the opening of the vagina. You're going to feel like it's hitting a wall. So all of these things matter. And sometimes someone is very aroused and it's actually the cervix that doesn't move nicely. So the cervix is like a tip of your nose. It should wiggle and jiggle around. And so sometimes I just have to work all around the nose or the cervix and loosen that up a little bit. And then it's more pliable. So I will on 100% of these people start with fascia. I have found people get better faster starting at the fascia, and most of the time I start at the abdomen and then I go to the inner thighs. There is a rare time I will start vaginally. It's very rare. In my career, I started vaginally because that's all I knew and that's all I was taught. And then I started experimenting. Well, what if I do this? Well, what if I do that? And I have found it's always faster when you do the fascial work first. And I've gotten to where I tell people now, my average patient, I'm seeing for 4 to 6 visits at this point. I used to do 12 visits. And now I found like this is really the most impactful, efficacious way of treating, getting them in and out of therapy.
I've heard how you describe the vestibule, and I would love if you could tell us because
Yes,
I've heard it's a really great description.
it's a whole body effort. The way I describe it differs based on the architecture in the room. But what I tell people is to create a visual is imagine a door with a door frame. And that door frame, let's say it's brown wood and the door is a white painted door. If you remove that brown wood, the door would still be there. The door frame is just aesthetic. It doesn't have to be there for that doorway to exist. So I tell people that door frame surrounding the door is like your vestibule. If you open the door, you walk into the vagina. The vagina is a hallway, it's a cave, it's up inside the body. So I tell people, listen, if this arch around the door frame, if the paint is peeling, if the wood has not been well taken care of, it's got splinters, then anything going through it, and I like to literally make my body as big as possible and walk through it and create friction along that door frame, that's not going to feel good. That's not going to feel neutral. That's going to be uncomfortable. And so what we do to fix that door frame is we put like proper wood lubrication on it, which in my metaphor is putting estrogen or estradiol and testosterone on that door frame, getting rid of the splinters and now making it a smooth area that a body like me or a dilator or a dildo or a vibrator or a penis finger toy friend, whatever can go inside without as much pain or with no pain at all.
I love it when you talk about why doctors don't realize people have pain with sex.
Oh, I love it too. I love to talk about that. So when I talk to people about pain at their vestibule, they're like, oh, my doctor never told me this. I'm like, no, because your doctor probably doesn't know what a vestibule is, number one. But also, they went straight with the speculum and they went through that door frame and they stretched it to capacity. And you were like, ow, ow, ow. And they're looking inside and they're like, no, looks good in here. And it does look good in there because you don't always look weird. You don't always turn red. You don't always have blood, even though it feels like you're bleeding, you're cut, you're torn. It feels like fire. There's no bonfire in there because they're not looking in the right spot. And that's a problem. That's one of several problems.
Yeah. And that vestibule is a very tiny little rim of skin. You have to kind of look out for it and know and listen to the patient. When does it hurt? When you have sex, and like it's at the opening, it's ground glass, it's ring of fire, it's terrible, it's terrible. And then using just a basic little Q-tip and just touching in that vestibule, and they say, ow, 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 ow. And then you can even kind of put the little Q-tip past their hymen. And, so I always say, like, is it okay if I put this past, just inside a little bit? And then I say, do you see how that doesn't hurt? And then they pull that little Q-tip right out and I start putting it right in that vestibule again. I said, this is the problem. Does this make sense? And this is why you have pain and why you have bladder problems. And we've talked about why this is bladder tissue and how some people can have bladder symptoms from this tissue. So did a talk with some OBGYN residents, and it was on vulvar pain. And of course, I talked about all the crazy things that can cause vulva pain, like, back injuries and whatnot. And one of the girls raised her hand. She said, what's like the basic thing you think like just an OBGYN should know from this talk? And I said, understand the vestibule. It's the most important thing, and your patients will love you and think you're the smartest person in the room. And it actually is fairly simple and easy once you really start to recognize it.
And I think most gynecologists don't know. I'm not most, but the people who don't know about it is because we never talked about this in residency. I never heard the word vestibule in residency.
Maybe vestibulitis if you were lucky.
But yeah, I mean, the vestibule is the MVP here. Like, the clitoris is, but I mean, is when there's a problem, I'm always going to look at the problem child, which is the vestibule.
Most of the time, clitoris can sometimes be the problem child, but
it's true. It's true.
Yep. And I think what frustrates me is that treating the vestibule is actually so easy. And there's just certain cue words. Like if you just actually listen to those words, everything would be getting better faster, Feel like I'm at the point where we have to equip the patient to give this information to the physician. I've worked in urology practices. I think urology is a place where they really need to know the vestibule. I would argue more so than the gynecologist because it is bladder and urethral tissue. It's endodermal tissue. So I think it's equally as important there.
No, definitely. I'm sure we'll do a whole episode on this, but as we're talking about the vestibule, sometimes I have patients that come in who tear right at that posterior fourchette vestibule area. That sometimes it's a hormonal issue, but sometimes there's a pelvic floor component to this. And I try to explain to them how if things are really tight, then the skin can't move so easily over that. Do you see patients for that? And do you find that the PT can help with that too?
Yeah. So, let's say they do have pain at the entry and it's not a hormonal cause because it's not always hormonal. It's most of the time it's hormonal, but it's not always. And that patient can't handle a finger going past the vestibule, the opening of the vagina. Well, that's where, it's really nice to do all that fascial work. But let's say I've cleared their fascia. It is time to go inside. Honestly, I'll go rectally if they're okay with it. It's the same muscles. It's the back half of the same muscles, and it can be profoundly helpful. Also, when and if it's time to go vaginally, I am very slow with that. There's a lot of fear involved. The brain is very powerful. So what I'll do is say, listen, I'm going to tell you what we're going to do. We're just going to introduce my finger to the vaginal opening. We're going to say hello, and we're just going to sit at the doormat. We're not going inside. I just want you to tell me what number the discomfort is. I want you to diaphragmatically breathe through it. And then we do that for a few minutes and the patient gets their head around it. And then maybe we do it again next time. And then maybe I go forward a millimeter or two. And then there gets to be a point where like, okay, we're in, they're fine, they know what to expect, and I can do good work.
The diaphragmatic breath that we're talking about, if you really breathe with your belly and not with just your chest, correct me if I'm wrong, you will do that and you just do an inhale and take air in your diaphragm, which is that smooth muscle kind of barrier, if you will, between your abdomen cavity and your chest cavity, but that will come down. And as that comes down, when you inhale, then your pelvic floor goes with it
Well,
down. And then when you
would go
exhale,
down
it
and
goes up.
relax with it.
Yeah.
And some people are incapable of getting their pelvic floor muscles to relax with that. So if I can put my finger vaginally or rectally, I can cue it a little bit more. But that's a very powerful tool for all sorts of pelvic floor issues. I'll tell people, hey, you can think of it as a vagina breath if you want. So when you inhale, you push the air down to your vagina. I say always, it feels weird, it feels backwards, and it feels like work because the diaphragm is a muscle. And so when you use it, you're like, this isn't just super passive. It's not. You're doing some work when you use your diaphragm.
I like the vagina breath.
I love
Yeah,
that.
I think that it cues people well. Be like, okay, let's push the air down into the vagina with the inhale. And if you're a man, say push it down into your anus. So there's ways to get everyone to do it. And then there's always the relax your anus, relax your abs, relax your anus. That helps relax the pelvic floor muscls throughout the day.
There you
I'm
go.
doing these things
Vagina.
as
Now
I'm
we're all
sitting
doing
here.
vagina breaths. We screw the
I know,
Kegels. We're doing vagina breaths.
What role do you think dilators play in all this? Do you generally recommend dilators?
I
Tell me
do
what you think about
recommend
that.
dilators for specific patients. I do not give it to everyone. The way I decide if a dilator is necessary is if somebody's struggling with girth in the stretching of the vestibule or the opening of the vagina, because some people don't have a vestibule, they've had it removed and they still have pain with sex. Has inappropriate removal, but we'll use a dilator. I will start, if a patient's in a lot of pain, I will start with a very well lubricated long stem Q-tip. And that's psychological. I know I'm not stretching the vaginal opening, but they're getting used to something going in the vagina. And when we can do that, then we work on twisting it, rolling it. So we're getting the fascia inside the vagina to get used to this movement, round movement, back and forth movement. And then I do a little bit of like, okay, let's put pressure around the clock at the opening of the vagina. So we're getting used to that mechanical input, and in our brain, we're saying this doesn't have to hurt. This doesn't have to be pain every time. That doesn't have to be my reflexive response. Once I can have them do that with minimal to no discomfort, and that's subjective to them. Does it feel like minimal to no discomfort? Then we can go to a dilator that is about the girth of my pinky, of a pinky, which is smaller than my index finger, which is what we use to do vaginal exams, unless you are a weirdo doing vaginal exams with a pinky. And I do think those people exist. I don't want to meet them. So we work on doing a well lubricated pinky sized dilator. Can you get it in? You don't have to get it in all at once. You can work on it in baby steps. You can do this for 10 minutes max, and that is it. Let's just do it twice a week. I don't want it to be daunting. I don't want it to be a burden. I don't want you to be anxious that you need to do this. I want you to know this is not allowed to hurt you. So it's very achievable. And then we build up to slightly bigger, slightly bigger, slightly bigger. So who do I use this for? I use it for the person who really gets anxious about the idea of something going in the vagina. That's the person I use it for.
Yep.
Yeah. And the
Yeah.
dilators basically are like, how would you describe them? Like a lot of them are silicone, some are kind of bendy, some are rigid, and they're kind of graded in size up. There's tube-like.
How do I say? It's like a cylinder. It's like it can be a soft cylinder or a hard cylinder, depending on how much you want to pay. It can have flowers on it. It can just be white. It could look like drumsticks, or it could be bendy. It can be red, orange, purple, green, blue, and you pay for it.
And you can buy them on Amazon.
You can buy all of them on Amazon, have them discreetly shipped to your door. But what I would never recommend with dilator use is using a size that hurts and just dealing with the pain, just shoving it in and sitting there with it in. And I will say that many people have been instructed to use it like that. I think that is completely counterproductive because this is a psychological tool. So we're just reinforcing the idea that things that go in hurt and I have to suffer through it and eventually the pain will go down.
It just reinforces that pain cycle.
I do think it's a more psychological tool. It's trying to like reverse that decision the brain has made that anything that goes in hurts and trying to reprogram the brain.
Sex shouldn't hurt. Gynecological exams shouldn't hurt. Tampons shouldn't hurt. And if you're a patient experiencing that, you need to find people like us that do this. But then if you're a provider and you see someone you're getting ready to do an exam on, and we all see it, you're getting ready to either touch and examine or you're getting ready to insert something in the vagina, and you see if their anus is at your eye level and it goes up to where your forehead is, they are telling you this is a no-go and you shouldn't try to force it. These are, I used to tell my patients, and people that trained me probably would strike me down with lightning, but there is no such thing as an emergency pap smear. We even have an at-home pap smear that just got FDA approved. Like
I
you
need a
can,
pap smear stat.
yeah, that doesn't exist, right? So you can recognize that and really make a difference in someone's life because they might just be suffering through it. So many women get told, power through, use lube, drink wine, all the crazy things we hear. And it doesn't have to be that way. And you can even be kind of the first line of defense if you're a provider, if you see that. Like there's no reason to force that to happen.
Absolutely. I always say, I don't actually even use speculums all that often when patients come in to see me for painful sex. I ask where their pain is. And if their pain's only at the opening, I don't need to be inside causing her more trauma. I have really small speculums in my office that I try to use because if someone's coming to see me for pain with sex, they've already been through a lot of trauma with their painful sex. Even if it's like consensual sex, I always say it's traumatic when it doesn't work because it's painful. They come in, and I think sometimes the fear of pain for an exam is part of what keeps people from actually coming in for this problem. So I agree. I always tell patients, like, we're going to take this super slow. Nothing has to be done, and a lot of it, so much of it is that vestibule and that opening and on the vulva that is important to look at.
I agree.
If people live in Dallas, and see Dr. McClure, that comes to you, where is another place patients could find a pelvic floor PT? If they live other places, or if their physician thinks they might need it, but they don't know who to send them to. Do you have any good resources for patients to find a good pelvic floor PT?
I have resources, and I will say that all pelvic floor PTs are really different because we also do not learn pelvic floor in PT school. We get about an hour, and it's usually about like pregnancy and leakage. Places where you can look for a directory of pelvic floor therapists are places like the International Society for the Study of Women's Sexual Health, so ISS, just do all the first letters, .org.
Ishwish.
Ishwish.org. You can look at the APTA has a group that used to be called the Section of Women's Health. Now it's called like Academy of like Pelvic Floor something or other. You can just put in those words, Academy of Pelvic Floor something or other, and it will pop up. You can find people in every state and every city there. I would also say that you can type in pelvic floor therapy in your city and that'll pop up. What I would always recommend someone do is actually call and say, hey, can I talk to one of your therapists? How do you treat pain with sex? And get a little bit of information. And if it sounds familiar, based on what you've heard here, then that might be a good idea. If it's like, oh, we do Kegels, I would be a little skeptical of that. Or we always do this, we always do that. Maybe ask like, do you ever suggest hormones? Is there ever a place for that? Just kind of interview them a little bit because this is a time commitment and this is very emotional. And so you really kind of want to get it done and get it done right and move on with your life. I would also say if you've already done pelvic floor therapy and it sounds nothing like what we're talking about, I would consider finding someone that sounds a little bit more like this. I have been the third, fourth, fifth, sixth, seventh, and even the eighth pelvic floor therapist that people have seen. That's because our educations are all so dramatically different.
You've been to PT, it didn't help. And I'll say, did they ever do an internal exam? And sometimes our patients say no. What are your thoughts on that? I personally think even if they're not routinely doing internal work in the vagina, they still need to evaluate those muscles at some point. I mean, that's an important part of this, right?
Yeah, you're not going to discharge someone from therapy without having ever gone in the vagina. That's not appropriate. I mean, you don't have to go in the vagina the first time. Sometimes I do. 50% of the time I go in the first day to assess. 50% of the time I don't, but I will never discharge them unless they moved, but I will never say you are done unless I've done that. So you do need to have it assessed. And the other thing is, if you're having your vaginal pelvic floor muscles assessed, they do not ask you if it hurts. They're just telling you you're tight or you're not tight. I would be a little nervous about that too.
And then what do you think about these telehealth PTs? I live in a big city. You guys live in a big city, but definitely I have patients that sometimes drive 2, 3 hours to come see me, and they live in small towns in my state, and they don't have access to pelvic floor PT on a regular basis. I have to think that telehealth PT serves a purpose, but I also wonder what you think of like how much can you really get done online or on virtual visits?
When COVID hit, I was at a big urology practice, and shockingly, they decided to keep the pelvic floor department going via telemed. And we were like, how are we going to do this? We're literally physical therapists. But it was amazing to see how many people truly did improve. It's with the education, honestly, doing a lot of awkward, like, do what I'm doing. Yes, like this. Does it feel like that? Bring your husband into the frame. Yes, no, do your thumbs like that. But also teaching about diaphragmatic breaths, knowing when to say, hey, I need you to go on your doctor's patient portal and you need to ask if they think you're appropriate for vaginal estrogen. To be honest, I don't say it like that. I say get some vaginal estrogen, but that's illegal. I'm a physical therapist. I'm not allowed to say that. So I don't ever say that.
Didn't hear
What I
anything.
just said is inaccurate. Don't edit that out though. Keep it in. But knowing when they need something that I can't provide, but they need to ask their doctor for, knowing to tell them, hey, these sexual positions will tighten the muscles more. Try this sexual position instead. Hey, you're constipated, consider A, B, C, and D. There's a lot of things I tell people on visit one, and I don't touch them. And it's lifestyle changes, it's habit changes, it's new habit implementation. So telemed done correctly can actually go a really long way.
Love
Interesting.
it.
During COVID, trying to do vulva was kind of hard.
Yeah.
That's not the easiest place to photograph for your
Yes.
doctor.
For vulvar dermatology things, like sometimes when patients message me that they have a bump, I'll say, you can send me a photo if you're comfortable with that in the compliant portal, all that. But yeah, to evaluate someone for painful sex without having to be able to fully see and touch is challenging. So I think it's awesome that you think that even the telehealth is something that can be beneficial for patients who can't access it in person.
Yeah, when done correctly.
Yeah.
Because that can go wrong really quickly.
Do you feel like Botox is helpful for what you do? Like if people get Botox injections in their pelvic floor, that's some kind of adjunct to your therapy? Is it helpful? Is it not?
I've had a handful of cases where it's been really, really helpful, but we do something really weird. Well, normally I've been able to work really well with those doctors and say, I'd like you to do Botox. I'd like you to focus on this, or I'd like you to focus on that. And then I want the patient to come in and see me literally the next day, and we'll do like a ton of treatment for several days in a row, where normally doctors will say, don't go to therapy for 2 weeks. But I have found some really profound improvement with these handful of cases. Since I've been in Dallas for the past 4 years, I don't know that I've recommended more than one person to do Botox in their muscles.
Yeah. I think that just goes to show there's definite synergy in what you do. And like you mentioned, having a C-section or tummy tuck and doing all those, doing that in conjunction with pelvic floor therapy. I mean, we see patients who have pain with sex, have prolapse and all the things, and they're going to go have a surgery. I think I would encourage them to do pelvic floor PT before, get your muscles ready. Just like, I mean, I had a hip surgery. I had to do rehab before I had my hip surgery to make sure my muscles were ready to take on what was coming when my post-op journey. And like, I think pelvic floor is not immune to that. I think it's a great tool, and you guys are under recognized and underutilized. Every day, I think what's so fun is we just go to the root. Like, what's the problem? You have constipation, you have diarrhea. Why are we throwing pills at that sometimes? It doesn't need that. Like, sometimes it's just pelvic floor PT, especially if you have bladder problems and you're pain with sex and orgasm troubles and things like that. They're telling you right there that their pelvic floor is too tight.
Yeah. Well, this has been awesome. Thank you for being on. I always tell patients, you guys are our miracle workers. I think you do such a great job. And sometimes patients will say, if there's someone who's been through an actual trauma or just kind of, scared about all of this, which is understandable if they've had a lot of pain, they feel nervous about going to you guys. But I haven't I just think that your job, maybe like ours, selects for people who really create a really safe space for patients. And I'm sure it's not everyone, but I find that I've never met a pelvic floor PT that I haven't been like, you have an amazing energy and create a really safe space for patients. So I think that you guys do a great job at that.
Thank you. Can I plug my Instagram? It's new.
For sure.
It's awkward. It's weird. It's all just random pelvic floor facts and opinions that are mine. None of it's medical information. It's I'm trying to think what it is. At Sauder Physical Therapy. So Sauder is Sauder Physical Therapy. If you don't know how to spell that, that's your fault.
It'll be in the show notes.
It'll be in the show notes.
Okay.
All right. Thank you for being here. It was great.
Yeah. The true MVP of Team Vulva is pelvic floor PT.
This is the true team.
This is it.
I love it. Thanks for joining us for this episode of Labia Logic.
We get it. Sharing a podcast like this might feel a little taboo, but we're here to break down those barriers. Labia Logic's all about empowerment, not embarrassment.
If you found this episode helpful, we hope you share it with others who could use a little labia logic in their lives. Can't we all? You can find us on all major podcast platforms and connect with us on Instagram at labia_logic.
From our lips to yours,
Viva la vulva!